Assalamu alaikum warahmatullah. Today we are going to discuss how to approach a case of SLE, Station 5 in MRCP basis exam, which is very frequent and common case in the exam. As we know, Station 5 is 10 minutes, 8 minutes with the patient and 2 minutes with the examiner. SLE can be presented in the scenario of this patient is complaining of both hand pain or both hands small joint pain, or may be presented as a case of skin rash. This patient is complaining of a skin rash. So your approach would be different according to the scenario. If the scenario is a small joint pain of both hands, so that the analysis of the complaint would be different. Uh, if the complaint is skin rash, so that the analysis of the complaint would be different. Okay, we are going to proceed the case as a case of small joint pain of both hands, which is more frequent in the exam. How to approach this case? As we know, the focused history, focused examination, and applying the patient concern. Uh, Focused history, the approach will be in the form of analysis of the complaint, onset, course, duration, progression, and asking about the nature of the pain if the if the complaint is post hand pain, to differentiate between rhinos and polyarthropathy and carpal tunnel. In polyarthropathy, the pain will be dull. In rhinos, it can be dull as well. In carpal tunnel, it will be pins and needles or burning sensation. You have to ask about the site of the pain. Is it on one hand or both hands for symmetry? And which joint is involved? Is it the knuckles or the far joint or the near joints? Why? Because we know that in rheumatoid arthritis, for example, it's affecting the metacarpopharyngeal joints, but in SLE or osteoarthritis or psoriatic arthropathy, it's more common with distal interphalangeal joint involvement. Worsening factors and improving factors. Anything worsen your condition, like exposure to cold or movement. Improving factor, anything improve your condition, like rest, warmness, or any drugs. Time of the pain. Why you are asking about the time of the pain? Because carpal tunnel, the pain will be more at the night. Any other joint involved, like back pain, grade of the pain from 0 to 10. 0 is the minimum and 10 is the maximum. Any morning stiffness, which is a very important question to be asked in any case of polyarthropathy, and for how long. In rheumatoid arthritis, it will be more than 1 hour. In osteoarthritis, psoriatic arthropathy, and SLE can be less than 1 hour. So again, this analysis of the complaint for any case of polyarthropathy. Actually, if any patient coming to you with a complaint of joint pain of both hands, so you have to approach the case with the same questions and the same scenario, which is fixed for all the cases of polyarthropathy. So when this joint pain started exactly, is it increasing, decreasing, or the same? Is it coming on and off all the time with you? Can you prescribe for me the nature of this pain? Is it burning, or dull, or electric light, or pins and needles? This is to differentiate between polyarthropathy, rhinos, and carpal tunnel. Can you mention for me, please, where is the pain in your hands exactly? Is it in the knuckles, the near joints, or far joints? Do you notice anything that worsens this pain, like exposure to cold or movement? Do you notice anything that improve this pain like rest or in drugs? Can you tell me please when this pain more? Is it at the morning, midday, or the night? Carbatana, it will be more at the night. Any other joint involved, any back pain? This for the cases of psoriatic arthritis, for example, can be associated with sacroiliitis and back pain. Uh, if we graded the pain from 0 to 10, 0 is the minimum and 10 is the maximum, how much do you give this pain? Is it associated with any morning stiffness in your hands? And if it is yes, so for how long this morning stiffness? And does it improve with movement? Okay, so this is the analysis of any case of arthropathy. As we agreed before, um, we approach the case as a case of small joint pain of both hands, a case of SLE. So the approach would be like that: onset of the pain, course of the pain, duration, progression, nature of the pain, site of the pain, worsening factor of the pain, improving factor of the pain, timing of the pain, any other joint involved, grade of the pain, morning stiffness. Okay. Uh, then in this case of polyarthropathy, we have to do differential diagnosis. What would be the differential diagnosis here? Any polyarthropathy can be due to psoriatic arthropathy, so that we have to ask about any skin rash. It can be because of enteropathic arthritis, so you have to ask about loose motions. Can be as a cause of reactive um, enteropathic arthropathy, so loose motions, reactive arthropathy, so you have to ask about burning during your water work. Any eye pain or redness because of, in a case of psoriatic arthropathy, it can be associated with uveitis, or in a case of rheumatoid arthritis, it can be associated with eye complication like scleritis, episcleritis, keratoconjunctivitis sicca, or others related to the drugs. Any finger color changes when exposed to cold weather, and this question actually is specific for Raynaud's phenomena. Raynaud's phenomena can be secondary, and it can be associated with any case of polyarthropathy like SLE, rheumatoid arthritis, systemic sclerosis. So it's also as well fixed question for all the cases of polyarthropathy. So we discovered that this patient has SLE, as the patient has joint pain both hands, and this joint pain associated with skin rash. And if there is skin rash, you have to do analysis of the rash, complete analysis of the rash. Where is this rash on, or when this rash started exactly, increasing, decreasing, or the same? Where is the rash in your body? It will be in the face. Is it increased with exposure to sun? So it is a rash which is characterized by photosensitivity and associated with polyarthropathy, so mostly the case would be SLE. At that time, you have to ask about other criteria of SLE. We know that we have 11 criteria for SLE. We will make it to make it easy for the candidate. Start from above. We'll make it so an anatomical distribution of the patient. So you have to ask about mouth sores. Following of here, joint pain. Of course, joint pain. We approached it before in the analysis, so no need to ask again. Cardiovascular symptoms because this patient may have pleuritis, pericarditis, myocarditis, lip-and-suck endocarditis. So you have to ask about all the cardiovascular symptoms: any chest pain, racing of heartbeats, shortness of breath, leg swelling, any lumpus or bumpus. They have also maybe lymphadenopathy, any pallor or fatigue for anemia, any change in urine amount or color, or any frozen urine or eye buffness. And these questions are specific for lupus nephritis, which can be involved. The kidney can be involved in SLE, lupus nephritis. Any seizures, weakness, sensory disturbance, or pins and needles. This is for lupus nephritis. SLE can be associated with antiphospholipid syndrome, so you can ask about any history of abortions, any history of blood clot, or family history of blood clot. Just these three questions are enough to ask about symptoms of antiphospholipid syndrome, may be secondary to SLE. Like that, you asked about the criteria of SLE. After that, you have to ask about other mixed connective tissue diseases may be involved with SLE. We know that SLE can be involved in overlapping syndrome, which can come with rheumatoid arthritis. So rheumatoid arthritis, ask about hand, any shortness of breath, because rheumatoid can be associated with lung fibrosis or cough, finger color changes in cold weather. All of these has been asked before, no need to ask again. For systemic sclerosis, you have to ask about difficulty of swallowing, okay, or maybe shiny tight skin as well. For dermatomyositis, you have to ask about any difficulty of combing your hair or getting up from a chair. This is for dermatomyositis, and also maybe complication. The patient may be receiving steroids, so also steroid can cause proximal myopathy. So for proximal myopathy of dermatomyositis, you have to ask about difficulty of combing your hair or getting up from a chair. Migraine also can be associated. Ask about dry mouth or gritty eye sensation. Then, as all the case of station 5, ask about social history, what the patient job and how much the job is or her job is affecting her usual daily activities, and or how much her symptoms affecting her job and usual daily activities, and refer the patient to social worker if her usual daily activities are affected, or refer the patient to occupational health care if her job is affected, with whom the patient is living, and financial support. Do the patient smoke or drink alcohol? Any medical history of long-standing disease like diabetes, hypertension, any family history of similar condition or long-standing disease? What's the drug list of the patient? I agree with you. It looks like long case. I agree with you completely. So that you have to make it so rapidly in the exam not to miss something. Yeah. But if you are practicing and you are doing practice for these cases with your colleagues and with your study partners, so that you'll find it so easy to approach and with limited time. So again, not to forget something: analysis of the complaint. If the complaint is joint pain, you have to do analysis of the joint pain by the same way we mentioned before. Then after that, systemic review or of differential diagnosis of polyarthropathy. 5 questions has to be asked. Then ask about criteria of SLE. Then ask about symptoms of other mixed connective tissue disease. Then social history, family history, medical history, drug list of the patient. What if the complaint is skin rash? This patient is, for example, 26 years old, female patient complaining of skin rash for the last 2 or 3 or 5 months, for example. So you have to do analysis of the skin rash. And we did analysis of the skin rash before in detailed manner with vitiligo and psoriasis. Also the onset of the rash, course, duration, progression of the rash, the site of the rash, and the body worsening factor, especially exposure to sun for this case because rash of SLE is photosensitive, improving factors like avoiding the sun or some local treatments, local creams. Uh, is this rash painful at all? Is it there any discharge coming out? Is it blanchable at all? Then to ask about any this skin rash, then I have to ask about any systemic review. You will find that this patient has also joint pain, in joint pain for SLE, and then do analysis also for the joint pain in this manner. Okay, like we discussed before. Systemic review, other systemic review would be the same also for this joint pain. Um, Criteria for SLE, as we discussed before. Symptoms of other mixed connective tissue disease, social history, medical history, family history, drug list. Let's agree that all the cases of polyarthropathy, otherwise rheumatoid arthritis or SLE or osteoarthritis or any joint pain at all, the approach will be the same. Um, so it is fixed approach for all the cases of polyarthropathy, especially rheumatoid arthritis, poly and osteoarthritis if it is coming in joints of both hands, arthritic arthropathy, psoriatic arthropathy as well is the complaint. This patient is coming complaining of pain in both joints of both hands. Okay, so for mixed connective tissue disease, this question will be fixed also for all the cases of SLE, systemic sclerosis, rheumatoid arthritis, because all of these cases coming overlap. So any case with rheumatoid, for example, you have to ask about mixed connective tissue disease symptoms, or systemic sclerosis, you have to ask about other mixed connective tissue disease symptoms, or the cases of SLE, like in our case today, you have to ask about all the symptoms of mixed connective tissue disease as well. Social history, don't forget, which is very important to mention. At this point, you can start your examination, not to waste time in social history, medical, family, and drug list of the patient. How to approach the examination for this patient? Okay, if the case came with polyarthropathy, let's agree also that the examination of polyarthropathy case will be the same also. We'll start with the hand examination. The complaint of the patient is both hand pain or small joint both hand pain. For any joint or polyarthropathy, look, feel, and move. Look, feel, and move. Okay. Look for joint swelling, deformity, skin rash, scars, pigmentation, muscle wasting, dorsal guttering. Feel, we will feel by two methods here. We will feel the joints, or will do delicate compression for the joints of both hands to know if it is soaring or not. And tell the patient, I'm going to do compression, delicate compression in the joints of your both hands. If it is soaring, please tell me. And then you can do palpation also by comparing the joints and the forearm by the dorsal aspect of your hand. This is to know if there is warmness or not. If there is warmness and there is soreness, it means that there is active synovitis with the patient. So feel by delicate compression of the small joints of both hands to know if it is suiting the patient or not, and feel also by palpating the joints of both hands and the forearms of the patient by the dorsal aspect of your hand to know if there is warmness or not of the joints, which indicates active synovitis. Move, this is the functional to assess the functional status of the hands. There is a lot of movements you can do for the patient by prayer sign, reversed prayer sign, a fist compression, picking up coins, buttoning and unbuttoning. You can do only 4 of these actions to know if there is functional impairment of the patient or not. Order the patient to do prayer sign, and you can act the prayer sign in front of the patient to make like it. Reverse the prayer sign by hyper flexion of the wrist joints. Fist compression, you can give him coin to pick up or to do buttoning or unbuttoning. Only 3 movements are enough. Then we'll go to the arm of the patient to make the patient to move his arms against resistance for proximal myopathy. Why proximal myopathy here? It may be involved in and polymyositis with the patient. Polymyositis can be, or dermatomyositis can be a part of overlapping syndrome, or maybe because of steroid the patient is receiving for SLE can cause proximal myopathy as well. Then SLE will start from the head. The head can have some symptom, the form signs in the form of cachexoid fissures, because this patient has an steroid therapy, so it may have cachexoid moon-like face, rounded face, plethoric, with acne vulgaris maybe, and maybe there is butterfly rash of the SLE. Okay. You have to examine the oral cavity for any sores, or mouth ulcers. Examine the scalp as well for any hair falling or scarring. The body of the patient, maybe there is truncal obesity and interscapular supraclavicular fat, trialband, striorubber as the complications of steroid. Cardiovascular system, you can see the GVP, murmurs, any murmurs for the patient, or by basal lung auscultation as a cause of heart failure, because there is cardiovascular complication of SLE. You can examine also the lung for pleural rub of pleuritis. You can examine the lower limb for edema as a complication of cardiac or renal involvement of SLE. Don't forget something important here. Jacquard arthropathy. What's Jacquard arthropathy? It is the SLE, or a special type of arthropathy of SLE, which is deforming arthropathy. We know that SLE has non-deforming asymmetrical polyarthropathy. But in this case, in Jacquard arthropathy associated with SLE, there is deforming arthropathy by making rheumatoid arthritis. How to differentiate? And this is tricky case actually, which can come in the exam and can be misdiagnosed as a case of rheumatoid arthritis because of the presence of deformities with the patient. How to differentiate between it and SLE, Jacquard arthropathy, and rheumatoid arthritis? That the deformity of SLE or Jacquard arthropathy can be corrected by flexion and extension and by functional movement. But in rheumatoid arthritis, the deformity is not corrected at all. And in X-ray finds also there is no changes of rheumatoid arthritis changes. We know that rheumatoid arthritis has X-ray changes, but in Jacquard arthropathy there is no changes at all. This is how to differentiate between Jacquard arthropathy and or deforming arthropathy of Jacquard arthropathy of SLE, and deforming arthropathy of rheumatoid arthritis. It will be corrected in Jacquard arthropathy, but it will not be corrected at all in rheumatoid arthritis. So how to present the case? What's your findings, doctor? You have to present your clinical findings only. There is no time. This patient, this young lady has non-deforming asymmetrical arthropathy in both hands. With you have to mention the if there is um, signs of active synovitis or not, and what about functional status. There is mild or there is evidence of mild synovitis in the form of mild soreness and warmness, and there is mild impaired functional status in ballooning and ballooning or picking up coins, evidenced by picking up coins. There is also, you can mention the others, signs of steroid therapy in the form of moon face, plethoric face, and truncal obesity, stria, alba or rubra. Okay, you can mention also if there is any other symptoms or any other signs with the patient as well, like butterfly rash you have to mention, or mouth sores you have to mention, or any other affection. You have to mention also in the examination, I'd like to do urine dipstick for this patient, not to be not to be forgotten that you have to mention I'd like to do for this patient urine dipstick for proteinuria during your examination as well. Okay, what concerns maybe the patient has, you have to ask about the concern. If you lost the concern, you lost all the exam. What could be the cause uh, of my joint pain of both hands, doctor? I appreciate your concern. Most probably you have a disease called SLE. It is due to disturbance in your defensive system which is supposed to attack the bugs and bacteria. In your condition it attacks many systems. One of them is the joints on both hands, and it can affect also other systems like the skin, causing facial rash, and it can affect also the heart, the kidney, the blood, and also the blood and the kidney. So what we are going to do for you is to do for you first a blood test, um, and urine analysis as well to confirm our diagnosis and to exclude the others. And they will refer you to a multidisciplinary team from rheumatologist and social worker, psychiatrist to give you the proper plan of management. And they can be kidney doctor also if there is kidney affection or the patient has positive data of lupus nephritis. Of course, if there is symptoms and or signs of lupus nephritis, tell the patient that we are going to refer you also to a kidney physician, and he may need a snip from your kidney uh, by a procedure under aseptic and under local painkiller to make to start the treatment or to make a staging for the disease and to start the treatment. We know that in SLE, if there is lupus nephritis or a urine analysis revealing that the patient has proteinuria, this patient has to undergo biopsy to know the staging of his lupus nephritis, and every stage has its own treatment. Is it curable condition, doctor? I'm sorry, it is not curable, but it can be controlled, and they will give you our um, and will give you the refer you to the multidisciplinary team to give you the appropriate treatment and to control your condition on medication and regular follow-up in the outpatient clinic. Um, Also, if there is skin rash, butterfly rash, you have to advise the patient to avoid sun exposure or to apply sunblocks as well. This is how to apply the concern of the patient. What is SLE simply? What you are going to confirm, how you are going to confirm, what you are going to do for the patient, partial blood test to confirm the diagnosis, and also maybe urine analysis, and also if the patient has symptoms of lupus nephritis, you can advise the patient that a snip from the kidney may be needed to know how much your kidney is affected from the disease, because every stage has its own treatment. Is it curable, doctor? I'm sorry, it is not curable, but it can be controlled by medication and regular follow-up in the outpatient clinic. I know it seems for you that it is a long case, but by practice and by repeated practice and by keeping this um, approach is fixed for all the case of polyarthropathy, it would be easy to approach, inshallah. Thank you, and see you in the next cases, inshallah.